maybe we'll start by 6:25. We'll begin. ऐसा करते हैं. There's still people joining. And Asmita, tell me when you make it live on YouTube, so we'll
Sir,
know
it's
that
live
also.
on YouTube.
It's already live on YouTube.
Live on YouTube.
It's already live. ठीक है,
Yeah.
ठीक है. Okay. So I will introduce him and then I'll ask you, Ajay, to start the welcome, Doctor, this one to start. ऐसा करता हूँ. हाँ?
Yeah.
ये क्या अभी डाला तुमने? शॉर्ट टर्म पोस्टीरियर.
हाँ, वो मेरे को एक पुराना मिला था जो मैंने पहले जो है उसको मैं एक्चुअली 1 साल पुराना है, मैं इसको एडिट करके डाल नहीं पाया था यूट्यूब पे। आज मैंने देखा इसको मैंने कहा इसको आप अपलोड करके डाला जाए एट द राइट टाइम।
Good. Okay, I think let's start. So today we are going to meet. Welcome everybody. We are going to listen to Dr. Dario and interact with him. Dr. Scocco is the head of the Neuro-Otology and Neuro-Ophthalm unit at the Institute of Neuroscience, Favaloro Foundation in Buenos Aires, Argentina. He also heads the Dizziness, Vertigo and Imbalance Clinic at INECO, again there. He has graduated from the University of Buenos Aires. He did his residency in the French hospital there, and later he specialized as a neurologist. And he is interested in neurotology, of course, but also neuro-ophthalmology, as do most neurologists who come into neurotology. They are also interested usually in neuro-ophthalm because of we keep seeing the eyes in neurotology. And he heads the video and nystagmography unit also. So he's heads the neuroscience unit there, and I will now hand over to Ajay to begin the proceedings.
And thank you, Dr. Sudhir. A few words about Dr. Dario Scocco. He is from Argentina. He had written 2 important papers in 2019 in Neurotology and Otology, and one in Elsewhere Journal in 2022. And these 2 papers have changed my practice as a neurotologist. What I used to struggle earlier was I would see patients with positionally triggered disease spells. They had this morning, and I would not see any nystagmus during the Dix-Hallpike test or supine roll test. Now I have extended my test battery of positional tests to half Hallpike testing, sitting up from the oculomotor patterns or sitting up from the Dix-Hallpike position, and the inversion test if I find a upbeating ipsitortinal nystagmus of more than a minute duration. And that's how I also picked up few cases which me and Sudhir reported in 2023. Setting up that is graviceptive heavy cupula and inversion test, with which we found many cases like Scocco's cases, and some cases associated with typical posterior canal, and we had reported this from our part of the country. Not as big as that of Scocco, but half of the cases we had 9 cases. So with this, I would request Dr. Scocco to start his talk. Please kindly pre-recorded talk.
Thank you very much, Dr. Sudhi Kothari, for inviting me to give this talk to the neurotology subsection of the Indian Academy of Neurology. It's a pleasure to me to talk about CTNAP BPPV, which is a variant of posterior canal BPPV that our group at Favalor Foundation at Buenos Aires, Argentina, have recently described. Vestibular symptoms on sitting up is a common in the general population and in patients seen by vestibular medicine specialists. When you see a patient with these symptoms, you should, of course, rule out hemodynamic orthostatic dizziness and vertigo, central positional nystagmus, vestibular migraine, PPPD, and structural abnormalities such as Chiari. Bucchi and Strothman reported in 2011 a variant of subjective vertigo without any oculomotor findings that they called BPPV type 2, in which patients complained of short spells of vertigo when sitting up from lateralized disc-Holpine maneuver. They took a series of 200 outpatients with vertigo or dizziness. 20% of them corresponded to classic variants of BPPV, but a larger group of 43% corresponding to what they call type 2 BPPV. It was a subclass of subjective vertigo. The symptoms arise when sitting up from one side, this Holpine maneuver, but not from the other side. So the symptoms were lateralized, and in some patients, they documented posturographic truncal oscillations on sitting up that could be documented by means of a posturographic examination bed. And they proposed a posterior canal short arm canal lithiasis as putative mechanism for this syndrome. In 2018, we started to notice this striking nystagmus pattern. This was a lady in which we performed an Epley maneuver for a classical right posterior canal BPPV the week before, and in this retest we can see how on sitting up from this Holpike maneuver, a beating right torsional nystagmus starts to develop, and the nystagmus pattern is suggestive of an ampulofugal stimulatory deflection of the right posterior cupula. We can see how it has a velocity pattern, crescendo and decrescendo velocity pattern, but not as paroxysmal as the classical variant of posterior canal BPPV. Most of these patients have been recently treated by means of canalate repositional maneuver for typical posterior canal BPPV ipsilateral to the suspected stimulated cupula on sitting up. This was another lady that was treated by a left posterior canal BPPV variant the week before. And we can see this beating left torsional nystagmus. In 2019, we published a series or retrospective series of 15 patients with this unusual nystagmus pattern on sitting up from this Holpike maneuver, and 8 of these patients were retested post-canal repositioning maneuver for typical posterior canal variant of BPPV treated by ourselves in our clinic, and 4 of them where early tests show less than an hour had passed from the original canalit repositional maneuver. 4 of these patients' canalit repositioning maneuver were performed in other clinics for positional vertigo, but we didn't have any data regarding the findings on those maneuvers, and all of them had history of recurrent vertigo or PPPV, and most patients reported vertigo on sitting up and persistent non-positional disequilibrium. We retrospectively review the videoculography data of these patients in order to try to find out which could be the mechanism involved in this striking nystagmus. And here we can see the different findings on the different positional maneuvers. And as you see, there wasn't a standard protocol because of the retrospective nature of this first series. All patients presented with the inclusion criterion, that was the presence of upbeating nystagmus with torsional component on sitting up. We also found that other positional maneuvers could elicit either an upbeating ipsilateral torsional upbeating torsional nystagmus with the torsional component directed to the ipsilateral side of the suspected posterior cupula stimulated, or a less intense downbeating contratorsional component. We can see in our series how 8 out of 10 patient tested elicit an upbeating ipsilateral torsional component in head yaw test to the ipsilateral side to the torsional component, and how 8 out of 9 patients tested elicit a less intense down beating contralateral torsional component on nose down position that is equivalent to the third step of the Epley maneuver. We can see in this lady that was treated the week before for a right posterior canal PPPV, how rolling her head to the right elicit an upbeating and sustained right torsional nystagmus. And when we roll her head to the left, a less intense downbeating with left torsional component nystagmus starts to develop. This other lady who was treated for a left posterior canal BPPV the week before, we can see how on nose down position, a downbeating with a slight right torsional component, nystagmus start to develop. That is such a sustained downbeating nystagmus suggestive of an ampulopetal inhibitory deflection of the cupula. So we elaborated a model in order to try to explain the findings on the different positional maneuvers. We initially proposed a preampular canalolithiasis in which there is an anatomical restriction on the distal movement of the debris. On whole pike, the otoconia will not move distally, and on sitting up, otolith should move near the ampulla by means of the negative inertia force, and then it should move distally by gravity and provoke a displacement of the endolymph, which in turn would elicit an ampullofugare cupular deflection, and hence the upbeating torsional nystagmus. When the otoconia impacts on the anatomical restriction, it generates a kind of valve mechanism like a partial canalid sham that prevents the backflow of the endolymph and so makes the cupula stay deflected for a longer period of time, and we see that non-paroxysmal crescendo and the crescendo nystagmus that lasts more than the typical variant of posterior canal BPPV. And this is an animation that will represent the model of the periampular canal lithiasis. Here we can see the two positions that mostly evoke nystagmus, which are those in which the periampular region of the posterior canal was closest to the vertical. In the follow-up of this series of patients, we saw no immediate response to canalit repositioning maneuvers. We tried with Epley, Semont, and the Misemont maneuver without immediate success. All patients resolved their positional vertigo and nystagmus by means of domiciliary Brandarov exercises, and 3 of them switched to typical posterior canal BPPV, 1 switched to horizontal canal BPPV. All of them had normal MRIs, and 3 patients recurred with ipsilateral posterior canal BPPV month after the index episode, and recurred with sitting up vertigo after the realization of Epley maneuver. So we continue looking for these unusual patients in order to test our hypothesis. And when they arrived, we saw some things which caught our attention and generated more questions and hypotheses. For example, we saw that on some patients there was almost no latency since the sitting up to the beginning of the nystagmus beating, like on this patient. We also saw on some patients that the nystagmus arised when sitting up from the other side, and that was not congruent with our model, like this patient, eliciting a right torsional abbeating nystagmus when sitting up from left this Holpach maneuver. And also in some patients, we also noticed a persistent nystagmus when rolling the head to the symptomatic side, and also that the nystagmus increased its velocity when the neck was flexed by 30 degrees, assuming the Holpach maneuver, like in this patient. And the Holpach maneuver is the position in which the posterior canal cupula is exposed maximally to the action of gravity force. So we start to look for modulation in the pitch plane, and we can see how this patient elicits an upbeating torsional nystagmus on sitting up from practice Holpach maneuver. When we roll her head to the right in the Holpach position, we can see how an upbeating right torsional nystagmus starts beating, that the nystagmus increased its velocity on flexing her neck, When we extend her neck by 20 degrees below horizontal plane, we can see how the nystagmus inhibits. And when we flex her neck again on the horizontal plane, we see the nystagmus starts beating with lesser velocity. And when we flex her neck again by 20 or 30 degrees, we can see that the nystagmus increase its velocity. We see how unrolling her head to the opposite side and downbeating contratorsional nystagmus starts beating, and it's maximal when the patient assumes the nose down position with the downbeating nystagmus with a slight left torsional component. That suggests an inhibitory deflection of the right posterior cupula. In order to test our hypothesis, we also tested sitting up the patient with less acceleration, and we saw that despite of being of less intensity, the nystagmus still showed up. Some patients had persistent stimulatory and inhibitory nystagmus depending on the head position. We also saw modulation on the pitch axis of the nystagmus direction and intensity. So we start to think that there probably was a graviceptive heavy cupula involved in the sitting up phenomenon, but there is not much literature regarding that topic. When we think on a heavy posterior canal cupula, we usually think on an persistent abetting ipsilateral torsional nystagmus when the head is assuming the Dix-Hallpike position. But there are series that show that that position could set the posterior canal cupula in a neutral position and eliciting no nystagmus. And some other authors have proposed that that position could set the cupula in a ampulopetal deflected position, evoking an inhibitory downbeating contratorsional nystagmus. So we see how interindividual differences on cupula angulation and the extent of neck extension during the maneuver could set the cupula on an ampulofugally or ampulopetally deflected position or even a neutral position. So on the heavy cupula hypothesis, the Hall-Hallpike maneuver will be the position which will expose the posterior canal cupula to maximally to the action of gravity, and so is the position with the greatest chances of eliciting a stimulatory upbeating torsional nystagmus. On the other hand, nose-down position is the other position that will expose the posterior cupula maximally to the action of gravity, but on the other direction, so eliciting an inhibitory down contratorsional nystagmus. And if there effectively is a posterior canal cupula involved in this phenomenon, a sitting position shouldn't be a neutral position, because in that position there is some partial impact of the gravity force over the posterior cupula. So an kind of set point adaptation probably is taking place. A similar phenomenon to which that was described by David C. and the John Hopkins group with the magnetic vestibular stimulation and also experiences with constant acceleration chair rotation. So on 2022, we reported a second series of 18 patients presenting with sitting up BPPV. And here we use a set of pre-established positional maneuvers in order to better characterize the mechanism of posterior canal cupula modulation. And when the nystagmus was observed, head position was maintained for at least 1 minute or until nystagmus vanished. All subjects were examined by video oculography on a weekly basis for 3 weeks, and only then, if the condition continued, it was carried out every 2 or 3 weeks until they resolved their symptoms and positional nystagmus. So age range from 47 to 78 years old, with a median of 62 years old, and there were 13 females. 12 patients presented with a documented or suggestive history of recurrent BPPV. 4 patients had personal history of migraine. 4 patients had been treated with Epley maneuver at our clinic for posterior canal canalolithiasis, and on 3 of them, the inclusion evaluation was an early retest in which less than an hour had passed from the original canalit repositioning maneuver. 3 patients were treated with the canalit reposition maneuver in other clinics, but we didn't have any data regarding the findings in those maneuvers. And time elapsed from the beginning of vestibular symptoms ranged from 2 days to 60 days with a median of 14 days. Most patients describe vertiginous symptoms when sitting up from bed, and most describe severe, persistent non-positional disequilibrium. And canalit reposition maneuvers were attempted on all patients without success for the treatment of the sitting up nystagmus in the initial evaluation, and all patients were prescribed with domiciliary Brandarov exercises. All of them resolved their symptoms between 2 and 45 days with a median of 14 days, and no patient showed evidence of central vestibular compromise in the neurological, oculomotor, nor on MRI examination. These were the findings on the different positional maneuvers or inclusion criterion. All but 1 patient presented the abetting ipsilateral torsional nystagmus on sitting up from this whole pie maneuver, but this patient presented the nystagmus when sitting up from straight head hanging maneuver. So 16 out of 18 patients in our series showed an abetting ipsilateral torsional component abetting nystagmus, suggestive of a stimulatory persistent deflection of the posterior cupula, and 11 patients also show a downbeating contratorsional nystagmus suggestive of ampulofugal inhibitory deflection of the posterior cupula. So the persistent and direction changing nature of the nystagmus on these patients suggested the presence of a posterior graviceptive heavy cupula. 5 patients presented the abetting torsional nystagmus on whole pike maneuver, but they did not present the downbeating nystagmus on nose down positions. We think that those patients probably had a short arm posterior canalolithiasis because they present the persistent upbeating torsional nystagmus on whole pike position, in which the debris on the utricular side of the ampulla will persistently stimulate the ampulla, and in nose-down position, the debris will fall towards the ampulla opening or towards the vestibule, relieving in that way the stimulation and evoking no nystagmus at all. We also saw that some patients presented with horizontal positional nystagmus, and we think that those findings could be due to free otoconia entering to the horizontal canal opening. So this is a nice case that I would like to show you. This was a man with 52 years old with previous history of typical BPPV, and he presented with positional vertigo for the last 24 hours. When we perform leaning test, he elicits a left horizontal nystagmus, and in bowing we can see a slight right beating nystagmus. On head yaw test, on the right position, we see a strong left horizontal nystagmus, and on left head yaw test, we can see a lighter right horizontal beating nystagmus. With a presumptive diagnosis of anterior arm left horizontal BPPV, the apogeotropic variant, we perform the Guffoni maneuver. And we follow with the Sumemaya maneuver. We can see here the geotropization of the horizontal nystagmus. So we move the otoliths to the posterior arm of the left horizontal canal. We retest the patient after 20 minutes, and on leaning we can see a slight upbeating left torsional nystagmus. Bowing elicits no nystagmus. Then we perform the upright head roll test for the previous finding of the horizontal BPPV, but it was negative. And we test the patient again with the roll test, and in the head yaw test in the left position, we see that the upbeat left torsional nystagmus appears and has a persistent nature. The nystagmus increases its velocity and presents with this persistent non-paroxysmal velocity pattern. When we sit the patient up, the nystagmus persists transiently. Then I tested this holdback maneuver that it was negative. And on sitting up from left this whole pipe maneuver. After some latency, we can see how the patient perceives a retropulsion and an upbeating left torsional nystagmus starts beating. Then we test the nose down position and we can see a lighter persistent downbeating right torsional nystagmus, suggestive of an inhibitory deflection of the left posterior cupula. So we think that the cause of this clinical picture was the movement from the anterior arm of the left horizontal canal towards the posterior canal short arm and the sitting up BPPV syndrome. So we saw that sitting up vertigo and sitting up nystagmus could be a epiphenomenon of the posterior canal heavy cupula and the posterior canal short arm canalithiasis. But what could be the mechanism involved in the nystagmus itself? So one possible mechanism could be that the detached debris that is located in the utricular side of the posterior canal cupula in the short arm canalolithiasis, but also could be some amount of detached debris in the in the heavy cupula associated to cupulolithiasis, move to the short arm opening or towards the vestibule when the patient extend their neck on the on the disc hold back maneuver or in straight head hanging maneuver. And then when the patient sits up, the debris will fall again towards the cupula by action of gravity, eliciting an ampliofugal stimulatory deflection and then the upbeating ipsitorsional nystagmus. Bucchi and Schwarzman have used this hypothesis as putative mechanism in the BPPV type 2, but they didn't found or they didn't show any oculomotor evidence that supports it. You can see here an animation that describes the mechanism. Another possible mechanism could be a disruption to posterior canal cupula adaptation. As we mentioned earlier, In the sitting position, the incidence of the gravity vector on posterior cupula is not maximal, but it's not neutral, so a set point adaptation process should probably take place. The stimulation on performing positional maneuvers could transiently disrupt such adaptation, thus making visible the stimulation of the posterior cupula on sitting position in the form of the sitting up nystagmus till the adaptation takes place again. Mechanism could be related to an overflow of the rotation feedback mechanism on the velocity storage. In normal conditions, the sitting up movement from this whole pipe maneuver elicits a posterior cupula ampulopetal deflection mediated by the endolymph inertia. When maneuver stops, a transient cupular ampulofugal deflection is produced by the moving endolymph in a phenomenon that is known as canal rotation after effects. We are not normally aware of such phenomenon since, in normal conditions, a corrective rotation signal of angular velocity opposite to the one produced by the canal rotation after effect is produced by the rotation feedback mechanism on the velocity storage, and the rotation canal after effect is cancelled. We hypothesize that, on sitting up from this whole pike maneuver in the context of a heavy posterior canal cupula, the gravity influence on cupula should elicit an abnormal and variable stimulus. Initially, at this whole pike position, a neutral or slightly inhibitory posterior canal cupula deflection is expected. The ampulopetal deflection expected during the head rotation could be altered by the simultaneous ampulofugal force mediated by gravity or by a different cupular dynamic. During the head rotation, gravity will exert an increasing force over cupula that will tend to deflect it ampulofugally till it reaches its maximum when the head is flexed by 30 degrees. From there, a decreasing but still ampulofugal gravity-mediated force is expected till the head reaches the sitting position. When the rotation stops, the gravity-induced ampulofugal excitatory deflection will add to the ampulofugal deflection mediated by the moving endolymph to then deliver an enhanced and abnormally persistent canal rotation after effect signal to the velocity storage. That anomalous rotation after effect will cause a large difference between the direction of gravity estimated by the integration of semicircular canal signals and the Otology signals, surpassing the correction capabilities of the rotation feedback mechanism, thus producing a nystagmus in the direction of the inhibited cupula during positioning. Here, an upbeating torsional nystagmus and a forwardly tilted estimated gravitational direction with a consequent retropulsion. A similar mechanism has been proposed for central paroxysmal positional nystagmus, where the abnormally enhanced rotation after effect is elicited by the disinhibition of irregular vestibular afferents, usually in the context of lesions involving the nodulus and the uvula. Just one patient in our series showed the typical persistent upbeating torsional nystagmus on this Holbach maneuver. 9 out of 11 heavy cupular pattern patients and 2 out of 5 short arm canal lithiasis pattern patients exhibited subtle, sustained, and asymptomatic downbeating torsional nystagmus on this Holbach maneuver, contralateral and ipsilateral, and straight head-hanging maneuver. This finding could be the result of an ampulopetal cupular deflection mediated by gravity if this heavy cupula was utricularly angulated, and another mechanism behind this downbeating nystagmus could be the expression of a posterior canal cupula adaptation to a persistent ampulofugal deflection on sitting position that is relieved or diminished on neck extension during positional maneuvers. Clinicians should be alert of these variations, since the presence of downbeat nystagmus on this hallpark or straight head-hanging maneuver could be erroneously interpreted as other vertical canal BPPV variants such as apogiotropic posterior canal BPPV or anterior canal BPPV, or as central positional nystagmus if graviseptic uvula signs were not looked for or were overlooked. So as conclusions, we can say that sitting up nystagmus could arise from heterogeneous mechanisms. The benefit of Randarov exercises over cannulate reposition maneuvers in our series is probably due to the fact that otoconia is not inside the semicircular canals, and this approach has better potential for detaching otoconia from cupula and for disaggregating free-floating otoconia on the vestibulum and on the posterior semicircular canal short arm. Therapeutic approaches will vary depending of the mechanism involved. We also try prolonged false position and domiciliary demi-Semon maneuver as used for apogiotropic posterior canal BPPV variant with success, but we have not yet compared different approaches in a randomized trial in order to compare effectiveness. And we have to underline that the syndrome could be very subtle and it could be missed if not explicitly looked for. This patient had had positional vertigo 72 hours before. He got better but remained dizzy and out of balance. And on examination, we can see this very subtle upbeating right torsional nystagmus. We should be very alert in order to see that finding. When we test the whole pike maneuver, we can see how a sustained upbeating right torsional nystagmus appears. And in nose down position, we can see the downbeating contratorsional nystagmus. So this variant could also be very subtle, so we have to be on the alert when examining the patient. We should look for it, because if we don't, we will probably not find it. So whole pipe position and nose down position are very important in order to not overlook this diagnosis, and this is a differential in which we have to think in a patient presenting with downbeating nystagmus, a positional downbeating nystagmus. And we think this mechanism could be related to post-cannulate repositional maneuver or residual dizziness in some patients. And we are prospectively evaluating more patients with these findings in order to better understand it, but they are very unusual. So thank you very much for your attention, and special thanks for the team of the Neurotology unit at Favaloro Foundation with Dr. Garcia and Dr. Barreiro.
Thank you. Thank you. Asmita, has Dr. Skoko joined?
Yeah.
Thank
There
you very
is.
much for the invitation.
Hi.
To present this talk.
Thank you. It was a very interesting and illuminating talk. We'll have a lot of questions. I think let's see if the audience first wants to ask any questions. Otherwise, I have quite a few, and
Okay.
I'm sure Ajay will have many questions for you. So maybe maybe we can just start with the questions. So in your first initial series, you found 40% of the patients had this sitting up type BPPV. That was quite high. Do you still get such a high percentage of patients with sitting up? The first
The,
series of 18, 19 cases that you had where you started, you found 20% had typical BPPV and 40% had this sitting up.
That is Bookie's series, sir.
So, do
That
you
is
yeah.
find more often typical? Okay, the
No.
first one in your
That 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 statistic is from the Buki and Strossman work. It's not my
okay,
findings. That they reported in the subjective vertigo and they reported the type 2 BPPV. They use that series, but no, I think it's more unusual in my experience. And these findings, these patients are more unusual. Probably the subjective complaints probably are higher in the statistical percentage of patients, but the oculomotor findings that are related with this particular syndrome are not so frequent.
book Scocco's first series was in 2019. That series was related to periampulary restricted posterior semicircular canalolithiasis, partial canal jam. That he had patient.
the animation.
Yeah, and now it is on the other side. That is on the short arm side. Came in 2022, where he had preset criterias like the half alpine, getting up from the alpine position, and then nose down position. That is the inversion position. So that is the
Right.
thing which has changed the scenario. And my practice to uh, a great extent after his paper of 2022.
So I think now every patient with BPPV, if you don't get on Dix Halpack, you don't get on roll, you must do the half Halpack also. You must try 2, 3 times because sometimes we've seen patient with BPPV. I do the left side and you get downbeating, and you think it might be some short arm or something on the left side, and then you again the right. The first time you did right Dix Halpack, you don't get anything, but the second time you do right Dix Halpack, then you get typical posterior canal BPPV on the right. So sometimes it can change during your
Yeah,
examination also.
yes, it's a bit tricky. All the BPPV syndromes, you have to repeat the maneuvers because probably in the first attempt you can see nothing, and then when you repeat the maneuvers, you can see the nystagmus. And also, in my experience, sometimes the sitting up BPPV is not expressed at the beginning of the examination, and then when you repeat the maneuvers, you can see it. And I think it's probably because the debris or the otoconia is located on the vestibulum. And then when you start moving the patient, the debris fall towards the ampulla, the posterior canal ampulla, and then the sitting up nystagmus expresses and also the findings on the whole pipe position.
Yes. So I had seen for quite some years, sometimes patients which you do a Dix Halpack, you don't get upbeating, but you do a roll, and when you do the head yaw test, you get upbeating. And I used to
Yeah.
think these were patients of posterior canal with a little different anatomy, but now looks like probably we missed them for it could have been this short arm or it could have been the upper side because they were patients who were getting, I think my connection is not good. They were getting nystagmus like you showed in the head yaw test, upbeating.
Hmm. Yeah.
But at that time, I did not do the half Halpike or other maneuvers. So maybe we missed them.
Yeah,
Uh,
I think the angulation of the head yaw test and the whole pike is not so different. So sometimes you can see it in the head yaw test, and the stimulus in that position is greater than the sitting up position itself. So you have more
yes.
chances to see the nystagmus in the whole pike or in the roll test than in the sitting up. But probably you will sit before in the sitting up because the first thing you test is this whole pike maneuver. So when you sit the patient up, you probably see it in the first place than doing the roll test.
Um, so can we need to there's one very complicated thing which Dr. Bijlani has also asked, and even I was going to ask, so he's made simple. I have not understood the reversal of the nystagmus direction on the basis of velocity storage. Can you explain that a little, because it was quite complicated for us to follow.
Yeah, it's an hypothesis trying to explain why the nystagmus arises in the context of a heavy cupola hypothesis. Normally, when you sit up from extending your neck, there is an fugal and ampulopetal inhibitory deflection of the posterior cupula, and when you reach the sitting position, there is a rotation counter-rotation deflection of the cupula with a stimulatory effect. That we are not aware of that effect because of a compensatory central compensatory mechanism that is the feedback rotation after effect in the velocity storage. When you have a heavy the head of the patient towards the sitting position. And when the patient
Okay, I think we are missing. The connection is not there. Can you hear him, Ajay?
No, I can't. I can't hear him.
Okay, great. Okay. Because my connection also not good, so I thought maybe I am missing.
That is basically explained by the disruption of the set point adaptation. Set point adaptation is a process where you stabilize the vision because a posterior cupula is not neutral in the sitting position. It is amplifugally deflected if it is heavy. So there would be a disruption of the vision when the patient with heavy cupula is static, sitting, or upright standing. And to compensate that disrupted that heavy cupula that amplifical deflection, there is a compensatory that effect, which is rotational feedback effect, after which that is called set point adaptation. So when the patient is brought back from the Dix Hallpike position to the sitting position, this set point adaptation breaks away. There is a disruption of set point adaptation. So that's why in patients with posterior cupulolithiasis, there is a nystagmus which is upbeating and ipsi-torsional even on getting up. Now this Coca is here to reply.
Dr. Dario, you're mute.
Yeah,
Yes,
I'm sorry. The connection stops and here we are
no
again.
problem. Okay, so
I don't know if you heard me the explanation.
no. Can you repeat, please?
Yes. Well, when you normally sits up from this whole pike maneuver, there is an inhibitory deflection of the cupula, and when you arrive to the sitting position, there is a transient stimulatory deflection of the cupula. That is the rotation after effect. We are not aware of that deflection because there is an internal mechanism on the velocity storage that compensates for that stimulation. That is the feedback, the rotation feedback mechanism. When you face the situation of a heavy cupula, when you sit up, the heavy cupula is deflecting continually this rotation after effect mechanism will add to the stimulatory deflection of the cupula mediated by the heavy cupula, and the rotation feedback mechanism is not able to compensate for that higher stimulation. And then the gravity signal is not well processed, and you have the retropulsion. The patient sees the retropulsion, and the nystagmus is not compensated, and you can see the upbeating nystagmus.
Okay, so again, the voice went away, but do I understand it right that normally when you get up, there is a mild inhibitory deflection of the cupula, which is compensated by the central mechanism. But when the
Yeah.
cupula is heavy, it is a stronger stimulus which cannot be compensated.
Exactly. That is the same that happens in, but it's the hypothesis that the Korean group of Kim proposed for central positional paroxysmal nystagmus. In that case, the feedback mechanism is not working well because a lack of inhibitory response of the irregular afferents by lesions of the nodulus and the uvula.
Okay. So Ajay has some questions. Ajay, go ahead.
The thing is that Skoko, how do you differentiate between the isolated short-arm posterior semicircular canalolithiasis with the cases where the short-arm posterior semicircular canalolithiasis is associated with cupulolithiasis, as in your 2022 paper? Because in both cases, the inversion test will be positive. That is, there will be inversion of the nystagmus in the nose down position, and there will be upbeating ipsitorsional nystagmus on getting up from the Dix pipe position. In one of my patients, which I reported in 2023, there was mild decrease in the intensity of the nystagmus in the nose down position. That we had graded that inversion test as negative, strongly positive, and moderately positive. Moderately positive, I mean to say that some of the particles which were on the short arm side of the posterior cupula, they were offloaded and it became milder on nose down position.
I'm sorry, I lost the
see, I think again you have lost that.
Okay. But I think, Ajay, what you're saying makes sense that roughly, if it is only cupulolithiasis, then when you do a half hull pike, you'll get
I'm
upbeating.
sorry, I lost the connection. Please repeat me the question because
only short arm canalolithiasis inversion test negative. Only cupulolithiasis, the inversion test, the nystagmus is as robust as it was in the half alpine position. And if there is mild attenuation of the nystagmus in the inversion position, then it would mean that both are present.
I'll put it another way. Can we compare the nystagmus in the half hull pike with the nose down and say that this is only canalolithiasis, or there is additional cupulolithiasis in plus canalolithiasis? Can we? I mean, sorry, is it only cupulolithiasis, or there is additional canalolithiasis? Can we sort of say that the nose down is less nystagmus as compared to the upbeating? I think his connection is poor, but I think roughly you can say that.
Now you
sorry, the connection is not working well. I'm sorry. The
I need to say when both are present, there is slight attenuation of the nystagmus in the nose down position. In the cupulolithiasis alone, it is as robust as it was in the half alpine position as it is in the inversion position. But when the two are present in the inversion position, it attenuates. Its slow phase velocity decreases. So there is a partial offloading of the canalolithiasis particles which were not adherent to the uterular side of the cupula. So that could make some difference.
Sorry, the connection comes and go. I can hear the entire question. You say
Okay.
that,
Ajay, why don't you write what you're saying so that will be easier. Uh, his question is while he's writing, I'll just say that when you have, how do you differentiate somebody who has short arm cupulolithiasis with additional short-arm cupulolithiasis in canalolithiasis also. So can you
yeah,
compare the upbeating and the nose down downbeating and say that there is not so much downbeating, so probably
mm,
there is a little bit of short-arm canalolithiasis.
yeah, I think it's very difficult to differentiate both situations, the heavy cupula and the heavy cupula plus short-term canalolithiasis, because when there is a canalolithiasis, the set point adaptation of the posterior cupula on sitting position could evoke also a downbeating nystagmus on the nose down position. So that downbeat nystagmus on the inversion test or the nose down position that is the same, is difficult to differentiate if it is the expression of the adapted cupula or the active deflection of the posterior cupula by a heavy cupula. So I think it's very difficult. I think probably the torsional component is an hypothesis that when you see a pure downbeat nystagmus, it's more possible that the downbeat nystagmus will be expression of the adapted cupula. And when you see the torsional component on the downbeat nystagmus, it's probably more possible to be due to an active inhibitory deflection by a heavy cupula. But it's just an hypothesis. I'm not sure of that.
Uh, One more complication is that you cannot directly compare the upbeating in half halpike with the downbeating in nose down because the canal angulation, the cupula angulation also varies between people. So if cupula angulation is different, you may not get that much downbeating.
Yeah. There are interindividual variations, and probably you can not see the nystagmus on the whole pipe position, but you can see it rolling the head in 0 degrees and at the level of the examination bed. Sometimes you can see better the upbeating torsional nystagmus when the head of the patient is flat on the examination bed, and it inhibits when you assumes the whole pipe position. So there are interindividual differences between patients, yeah. And
Uh,
sometimes I have seen that it's more visible, the inhibitory nystagmus in the nose down position than the stimulatory nystagmus on the head test or whole pipe position.
one
I
more
think
point, I
that
think, Doctor. Sorry, you were saying.
No,
Uh,
I think that that's more because the phenomenon of the adapted cupula that is more visible. That phenomenon of the cupula is adapted when you uh, put the head on the nose down position, that trying to stimulate an already stimulated cupula by whole pipe position or the sitting up.
one more question, Dario. Uh,
Yeah.
Ajay,
all
on this same point still, that Dr. Bijlani has pointed out, which is the point that you and I, Ajay, had also discussed in your case, that if it is only cupulolithiasis, there would be no latency for the upbeating nystagmus when you take it. But if you get a little latency and slight build-up, that might suggest the particles are falling on the cupula and therefore it is possibly short-arm canalolithiasis.
Yeah, I agree with that.
according to you, every patient of posterior heavy cupula due to cupulolithiasis would have the same type of nystagmus on getting up from the dicksulpike position. That is, if it is upbeating right torsional in the right dicksulpike, it will be right torsional upbeating in the getting up from the dicksulpike position. So suppose in a case where you have a persistent upbeating geotropic upbeating nystagmus ipsi torsional on right dick sulpi position, and you get a reversal nystagmus, that is downbeating and left torsional, is it possible to say that the cupulolithiasis of posterior canal, either on the canal or the uticular side, is associated with typical periampullary posterior semicircular canalolithiasis without jump?
You refer to the first model of the periampular anatomical restriction of the
No.
okay.
Typical periampullary. That is the classic variant. When you get a upbeating nystagmus in the right dick sulpi position, which is
Yeah.
persistent with a positive inversion test on nose down to the opposite side, and when you do a second dick sulpi test and make the patient sit up, you get a inversion nystagmus, which we usually see in the classic type of BPPV. So can we say that the cupulolithiasis and canalolithiasis are coexisting?
Yeah, I don't know if I
No,
understood
we
the
didn't get.
question correctly.
I repeat it again.
Yeah,
Normally, a posterior cupula which is heavy because of
Yes.
cupulolithiasis, either on the
yeah,
canal short arm side or long arm side,
yeah.
adherent cupulolithiasis, will have a persistent upbeating nystagmus in the dick sulpi position. Say it is angulated in such a way that it is canal angulated. Okay,
Hmm.
cupula. And we have
Yeah.
got a upbeating persistent nystagmus more than 1 minute. When we do an inversion test from right dick sulpi to the nose down to the left lateral recumbent with nose down, it
Hmm.
inverses direction. It becomes downbeating and left torsional. Okay, so it is cupulolithiasis by all
Yeah.
means. So now we again take the patient to the dick sulpi position. We see the nystagmus which is persistent right torsional for 1 minute, and now we take up from the dick sulpi position, and now we get, instead of the same type of nystagmus upbeating and right torsional, we get downbeating and left torsional. That is what we usually see in the typical classic posterior canal BPPV. So in such cases, can we say that the posterior cupulolithiasis is co-occurring with typical classic posterior canal BPPV?
I'm sorry, I didn't get the question right.
So you are Ajay, you are saying the person has typical posterior canal BPPV plus cupulolithiasis.
Yeah. The two are occurring together.
So how would the nystagmus pattern be if the person has both cupulolithiasis as well as a normal, I mean, the routine posterior canal BPPV? Because in routine posterior canal, when you bring the patient up, you get downbeating and opposites
Yeah,
torsion.
we have all the features of a persistent nystagmus in the dick sulpi position lasting more than a minute, and in inversion
I s-
position is reversing the pattern of the nystagmus. But when we make the patient sit up from the dick sulpi position, it becomes downbeating and left torsional, contratorsional. So that is not expected of a posterior heavy cupula. It should be same. So if it was right torsional and upbeating in the right dick sulpi position, it should be right torsional and upbeating in the getting up from the right dick sulpi position because of the disruption of set point adaptation. And if you don't get this sort of nystagmus, but a nystagmus which is downbeating and contratorsional, that is left torsional and downbeating, on getting up from the right dick sulpi position, in such a situation, would you suggest that the two conditions are existing? That is the posterior cupulolithiasis of right side with posterior typical canal, posterior canal BPPV. That is my question.
Um,
I'm 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 sorry, but the connection faded away. I will answer what I interpreted from the question. I think that if you have both pathologies, the heavy cupula and the long arm canalithiasis
Yeah.
together, you can see probably a mix of patterns. You can see and paroxysmal upbeating torsional nystagmus, but that don't fade away totally and persist with an upbeating torsional nystagmus during the disc hole pike position. And then when you sit the patient up, I think it's very difficult to predict what it could happen there. Probably you will have the typical inversion nystagmus when you sit the patient up from the otoliths moving towards the cupula, and I don't know if there is a other component coming from the heavy cupula stimulated during that movement, but I think it's very difficult to predict that pattern, and probably you will differentiate it more after treating the canal lithiasis with the Epley
Yeah.
maneuver and see the result after that.
I have one patient which I will send you on email because I was always looking for patterns on sitting up from the sulfide position in heavy graviceptive cupula due to cupulolithasis, and most of them would have the same kind of nystagmus which they had in the Dix half-pike position or half half-pike position. But here I had a patient who had patterns, all patterns suggestive of heavy cupula due to cupulolithasis in the right disc half-pike position. But when I take them up from the half-pike position, there is a reversal nystagmus typical of typical posterior semicircular canal PPPV. So that is a
Yeah.
soft pointer that the two conditions may exist.
Yes,
Yeah,
Ajay,
yeah,
one
probably.
more point what Dario pointed out is what we should see for is it paroxysmal? Is there a persistent nystagmus that suggests cupulolithiasis? If there is additional paroxysmal component to that, that is suggesting that there are some particles also which are free and floating.
Yeah.
Yeah, I think the paroxysmal pattern is more suggestive of free otoconia moving on the canal. Yeah, I think this. But probably it's very difficult to predict the mechanism just for the examination. You have to see the response to the maneuvers that you try with that patient and the evolution of the patient. I think in one particular patient, we don't have the final mechanism in each patient. It's very
Uh,
difficult to predict.
Did you have any patients which were confirmed as the first in your series? You said there was a restriction, and that's why you got this, and they got converted to typical long arm posterior canal. So probably there was a restriction, and the particles went through, and those patients got converted to typical long arm, because those who are on the short arm side, they would not come here in the long arm. So they would
Mhm.
get either a horizontal canal or like some of the patients that Ajay, we've been seeing
I,
some of his patients.
we have reported one such patient where
Yes.
we did the repeated positioning suggested by Buki, taking to the Dix half-pike, getting up, and again taking multiple times, and that patient converted into to the typical variant. And I had reported that patient. That I will also send you, Dario.
Yeah, it's yeah. I have seen some of them. In the paper is reported that some of these patients convert to typical posterior canal. I think that they're probably because of the first hypothesis of the restriction that the debris passed through the restriction, or probably because the cupulolithiasis detach from the cupula and moves freely on the in the posterior canal. I think both possibilities are possible.
Uh, would you like to do only Dick's Branderoff exercises, or maybe vibrate them and then do Branderoff now? Because we are
I,
thinking of particles adherent. So, what is your feeling about vibration?
No, I do both or all of them. In the consultation room, I usually do vibration or mastoid vibration when I put the patient in nose down position and then I apply mastoid vibration. Then I usually do a few demi-Semon maneuvers. Parting from the nose down position. And I say to the patient that continue with Brandarov exercises or straight head hanging exercises on bed in their homes. And usually, in the first control, after a week, the patient feels better. Probably they resolve their nystagmus too, or probably there are some nystagmus that disappears in the evolution in the next weeks.
So Dr. Sushma asked the same question that do you think this demi-Simont maneuver is more effective or Brandarov? But I think we do all and you try.
Yeah, demi-semon is more easily performed in the consultation room, so by ourselves. But it's very difficult that the patient resolve the nystagmus in the first attempt.
Yeah.
Think just one patient I saw that I could resolve the nystagmus in the first attempt in the first visit. So I think the domiciliary exercises and the time itself is better for treating these patients. And when you see in the next control, you probably see the clinical picture is resolved or resolving, but it's very difficult to measure effectiveness between methods when you probably don't resolve the nice.
Have you seen a recent paper from North America from Janet Hermansky only a few days back that was trying to say that most of the short-term posterior semicircular canal BPPV is cupulolithiasis, and they have found the downbeat nystagmus in their series.
I think he's got disconnected. But Dr. Mohandas has asked the same question which I was going to ask is what is his experience with the bow and yaw maneuver for these short arm? So I think that's an interesting, yes. Okay, go ahead, Ajay.
Yeah, from North America, a few writers, Helmensky Janet has recently reported only a few days back that most of the short-term posterior canal BPPV is in fact short-term side posterior cupulolithiasis, and they found a downbeating nystagmus during the Dix-Hallpike or extended Dix-Hallpike position. They, instead of taking the head to 30 degree, took to 40 degree, and they found a downbeating nystagmus. So, do you see that there is a spectrum from short-arm side posterior semicircular canalolithiasis to cupulolithiasis? Because some of them patient, some of the group, especially of the Chicago group of the Janet Helmensky, they are saying that they have seen more of the downbeating nystagmus in the half alpine this positional test in their reported case of short-arm posterior semicircular canal BPPV. Or do the North Americans have a cupula whose angulation is different from those of the Indians and Argentinians?
But what about the nose down inversion test in those patients?
And they have done. They have done.
So what did it show?
It inverted.
Okay. But I think, Dario, I mean, like what Ajay is saying, is there a spectrum? So I think there will be a spectrum of patients who have all the particles adherent to the cupula, some adherent and non-adherent. So it could be sort of different degrees of adherence on the short arm side.
Yeah, yeah, I think what I said before, it's very difficult to say if it's adherent or not adherent if you consider the hypothesis of the set point adaptation of the posterior cupula. So when you assume the roll test to the asymptomatic side of the nose down position, you are not sure if you are what the downbeat you're watching is an active adherent particle that is inhibiting the posterior cupula or is an expression of the cupula adaptation. So I think I don't know if you have a clinical sign to differentiate both states. So I don't know what we are
About the
watching at.
duration, if you get persistent downbeating, that will probably suggest adherent cupula. set point adaptation will not go on for too long.
Yeah, but the adapted cupula, what the magnetic vestibular stimulation, and also the when you perform a caloric test, the inversion nystagmus that you see after the stimulation is also very prolonged. So I think you should watch the nystagmus, but a very long time in order to see if there is fatigue or not, and differentiate between an adapted cupula or an active inhibition by an adherent particle.
One more question about the bow and yaw maneuver. What is your experience with it? Have you tried it in the short arm canalolithiasis? And there's some paper which said that 40% of their patients of posterior canal were short arm. So they first do the bow and yaw. If it doesn't go with that, then they go try the Dix Harpax. So do you think that percentage is so high? We are trying to see our patients, but we have not found so high yet.
No, I don't generally use it at the first attempt because I think that you should try with the maneuver that has more chances to elicit the nystagmus and to not fatigate the peripheral reflex. So in the first attempt, you should do the Dix-Hallpike maneuver. That is the maneuver that has more chances to elicit an autoconial movement. The so I use it in order to differentiate the geotropic of apogeotropic variant for lateral canal BPPV mostly, but not for posterior canal BPPV.
There's one question, I think Dr. Vinayak has asked in Brander of exercise at home, how many patients get free of their symptoms or go into remission? It will depend. I think it depends on which type of BPPV you are talking about, but how will you answer this?
I don't have now. I think it's reconnecting.
Yeah, so how effective is our Brander of exercises for BPPV in general and for the sitting up vertigo?
Hi, have you heard me?
Yes, no, we didn't hear you. South America is far away. The internet is also far away for them.
Well,
So, what is your experience? How will you answer this, Ajay? The effectiveness of Brander of exercises in general and for short term, the sitting up vertigo.
see, for setting up vertigo as proposed by the SCOCO 2022 in his series of 18 patients, they were effective in a myriad of 2 to 6 weeks in almost all patients, 14 to 45 days in almost all patients. So that's what SCOCO reported in 2022. About the in general, I was advocating the brand of exercises only for patients with posterior cupulolisthesis before the bascule maneuver came in the last Barani meet. So now all patients, instead of sending home with the advice to do blender of exercises, I've been advising them the bascule maneuver, and that's what I do.
I,
That's my take for blender. Now this Coco is back.
Yeah,
I
Dario,
sorry.
the question is what is the place of Brander of exercises in BPPV? Where do you use it and how effective is it?
No, I use it mostly in these atypical variants in the posterior canal in the sitting up BPPV on subjective vertigo without nystagmus. I don't usually use it in typical variants. I have the typical approach of canality repositioning maneuvers, but I don't usually give to the patients the indication of continue with Brandarov exercises in their homes with we have a typical variant of BPPV.
When somebody has very severe BPPV, I would advise not to do brand arrow because you're going to put the canals into multiple positions and make it difficult for the neuro-otologist later. But
Yeah.
those patients who have very mild symptoms, it's worth trying. And where you can't really don't have a mass of particles to do a repositioning, where there is not enough inertia or gravity, maybe you can. But I wanted to ask that when you do this brander of exercises, if it is lateral canal, when suppose you had a patient of lateral canal BPPV and you have another patient of posterior canal, after treatment, if they still have some symptoms, do you advise them in the lateral canal to keep his head like this and go down, or we do the usual brander off with the head turned things? Do you
Uh,
modify the brander of exercises for the head canal position?
After an horizontal canal, you say if the patient. No, I don't usually indicate Brandarov if I see a typical variant or horizontal or posterior variant. I prefer to insist with canal repositioning maneuvers and probably force position at home for for lateral canal BPPV. But I don't usually indicate Brandarov exercises for those variants.
So you do advise the patient to sleep on the healthy ear later on for at least for 1 or 2 days as far as possible.
Yeah, yeah.
I had a
And
question.
and in the posterior canal BPPV, I usually indicates to after the typical Ipley maneuver to sleep with two pillows and not go. But there is evidence that there is not adds performance to the maneuver, but I think that in these new variants, in this the sitting up BPPV and short arm canalitiasis, probably these restrictions could take some place. I think that they were not evaluated for this, the restriction indication post canali repositioning maneuver. So I have not evidence, but I indicates that to my patients.
So, this subjective BPPV, I used to think that if you see a patient with no nystagmus, but if you visually with your eyes, maybe it could still be subjective. But if even on VNG, if you don't even see a little torsion, little downbeat, probably it's not BPPV. Would you agree, or do you think that in these sitting up vertigo, you may have patients with no nystagmus at all?
Yeah, I think that is a spectrum that what the book reported on the first place. I don't know. I assume that they look for nystagmus in all positions. They don't describe any nystagmus, but I have some patients that pass from having the typical sitting up BPPV to no nystagmus, but with some symptoms. In those patients, probably you don't see nystagmus when sitting up or in whole pipe position, but you can see the inhibitory nystagmus and nose down position. So I think that the last sign of that last resolve is the downbeat in the inhibitory downbeat in nystagmus. So I have had some patients that the stimulatory abtorsional nystagmus fades away, but the downbeat in nystagmus in nose down position still is there, or in the contralateral disc whole pipe position. You can see it there too.
Okay. Ajay, you have any question? Otherwise, I still have one or two.
No, I'll be leaving because I have to go for marriage. But I have been greatly impressed by this great man. He has changed my practice over past 2 years. Ever since I read his paper of 2019 and then 2022. When 2022 paper came, I thought that the 2019 hypothesis may not be correct. But then again, I had a patient which proved his 2019 hypothesis of periampullary restricted posterior semicircular canalolithiasis with partial canal jam, and I also reported that patient. So I think he is one of my distant mentors as well. So thank you, Skoko. I'm leaving this webinar
So, so,
Thank
with
you.
great
but
thanks
before
to you
you go,
and
no,
salute to you.
before you go, I want to say that he is by proxy for me because you got influenced by him and I got influenced by you because Ajay started looking at all these variants. So now I also look at all these short term and things, and we've been publishing together. So we have been trying to, calculate and see where could the particles have gone and where, and it's become very interesting. Otherwise, BPPV was posterior canal, lateral canal.
Mhm.
It's become really interesting.
So
Uh,
Yeah, I think
double
it's
I,
salute
the
to
fun
you.
part. It's the fun part of our practice, just to
yes,
try
yes.
to solve
I'm
Visualize.
leaving
the
now.
paper.
I'm leaving. Okay.
Yes, visualize.
Thank you.
Dario, I had one question before we disperse. When we see when we have a typical long arm posterior canal BPPV and we reposition it, at the end of it, sometimes I immediately check the patient as soon as I've done the reposition to make sure it is gone. So we often get downbeat and little, but patient hardly has any symptoms, and when he comes back after 2 days, it is gone. So is it because of set point adaptation, or is it because the particles have gone on the other side? Why do they get downbeating?
Yeah, I think I have the experience that when you early recheck the patients, you have more chances of look for one of these variants. Or the sitting up, the most patients with sitting up we have seen in this early retest. So it's probably when when you move the particle from the long arm to the vestibule by the Epley maneuver, they fall to the posterior canal short arm. So when you retest the patient, probably you see that downbeat nystagmus, probably you're watching the short adaptation relieve on positioning the extended neck. And that phenomenon is probably asymptomatic. And if you test the same patient, not immediately, but 7 days after the index maneuver, probably you don't see nothing. So
Right.
yes, it will be interesting to follow a cohort of patients with day after day, and see what the findings are.
Okay. Thank you, Dario. This was a very nice talk, and we hope to have you again sometime soon. And
Thank you.
it's been very interesting. Thank you, everybody, for the participation, and I thank the IN subsection also.
Thank you
Thank
very
you.
much for
There's
the
one last
invitation, and
question. Okay,
I'm
there's
sorry
one
for the
question Dr.
connection
Shifali
problem.
has asked. How Right, that's fine. How do you differentiate anterior canal BPPV from these variants? Is what Dr. Shifali has asked. So, when will you suspect anterior canal? Because you are getting downbeating here. So, um, let me try to answer. Then you correct me. If you are getting downbeating, but when you do a inversion test, the ones that we are talking about here usually have upbeating, and when you do the head down, you are getting downbeating. In anterior canal, you will get downbeating. Sometimes it's difficult to distinguish anterior canal from the epigeotropic variety of posterior canal, but that also we can now. We can quite often distinguish. In fact, the more brisk nystagmus usually turn out to be epigeotropic posterior canal BPPV. So, can you answer that question for her? That she wants to know how do you distinguish anterior canal BPPV from these atypical variants of
Yeah,
posterior
I
canal?
think that you will see a stimulatory upbeating nystagmus in the half whole pike position in these variants, because you have some extent of stimulatory deflection of the posterior cupula you will see it on the roll test or in the whole hole pipe test. And you will see, you can get confused with the downbeating nystagmus, and you can think on differential diagnosis with anterior canal BPPV by the downbeating component. But you will see an upbeating stimulatory nystagmus when you test for a whole pipe in whole pipe position.
Okay, I think we'll call it a day. Have a great Sunday ahead, and thank you for the nice talk. Thank you,
Well,
everybody.
thank you very much, and see you later.